When we look at transudate versus exudate, this is a way of us explaining or describing the fluid that is in the pleural space. So if we have transudate, this is a thin watery fluid from the pulmonary capillaries. So a CHF may be an example of, or the etiology of CHF would have more of a thin watery fluid from the pulmonary capillaries. When we look at exudate, this is going to be a protein-filled fluid from inflammation, maybe an infection or malignancy, some sort of tumor that would be excreting the exudate. So transudate thin, exudate extra thick. I don't know. I just find ways to make things make sense and click for me. So transudate versus exudate. Other ways that we can break this down is if we look at the total protein. So we've talked about a thoracentesis before, and in that thoracentesis, it is draining the pleural fluid from the pleural space. Part of what we can do with that is we can measure the pleural fluid through our arterial blood gas machines. And when we do that, we look at the total proteins, we can look at the ratio between fluids and proteins, we can look at the lactate levels, we can look at a ratio between the LDH of fluid and the LDH of serum, and then we can actually look at the cholesterol, which all break down and help us identify and differentiate transudate versus exudate. So breaking it down, your total proteins, if it's less than 3 grams per deciliter, we're thinking transudate. If it's less than 0.5 ratio of transpulmonary fluid versus the blood, then you're looking transudate. When we get pleural fluid that has a lactate, the lactate of the pleural fluid, if it's less than 200, then we're thinking transudate, and that ratio less than 0.6 is transudate, and then the fluid cholesterol less than 60. We're all identifying the less thans as a transudate. Remember, the transudate is going to be thin. The exudates are going to be extra thick, so they're going to have more proteins, they're going to have more elements in that fluid, creating greater numbers when it comes to these measured values. So we're going to continue to kind of break down the transudative versus the exudative fluids. When we look at the transudate, typically this comes from CHF, like we said, or congestive heart failure. So we can have left-sided heart failure or we can have right-sided heart failure. When we look at left-sided heart failure, we're typically thinking of congestive heart failure. When we think of right-sided heart failure, we're thinking cor pulmonale. So remember to differentiate the two between congestive heart failure and cor pulmonale. When we look at the left side, it's increasing the hydrostatic pressure in the pulmonary circulation. And this decreases the rate of pleural fluid absorption. So the body is no longer absorbing the pleural fluid, and you get this increase in pleural fluid in pulmonary circulation. And it changes the pressure in the pleural space. So when that hydrostatic pressure goes up, you're going to start to see fluid move into the visceral pleura, into the pleural space. So it's moving through the visceral pleura into the pleural space. When we have all of that extra fluid that's in our pulmonary circulation, that hydrostatic pressure is going to go up. That hydrostatic pressure goes up, fluid's going to want to leak out. When the hydrostatic pressure is high, fluid wants to leak out. When it's greater than the oncotic pressure, hydrostatic is high. When it's greater than the oncotic pressure, fluid wants to leak out. So left-sided heart failure, you get increase in hydrostatic pressure, you get an increase in pulmonary circulation from all of the extra fluid. Then that increases the hydrostatic pressure, decreasing the amount of fluid that's being absorbed, changing the pressure in the pleural space, moving fluid from the visceral pleura into the pleural space. So that's left-sided heart failure. When we look at right-sided heart failure, this is an increase of hydrostatic pressure from systemic circulation. So this is backing up from the system, moving into pulmonary circulation. The lymphatics cannot keep up with the amount of fluid that is being backed up, and it changes the pressure in the pleural space. But this is a movement of fluid from that changing pressure in the pleural space is allowing fluid to accumulate in the pleural space. So the right side comes from systemic circulation, the left side comes from pulmonary circulation. So we have what's called a hepatic hydrochlorox. So we have what's called a hepatic hydrothorax. So with a hepatic hydrothorax, what we're seeing here is the liver not doing its job to move or eliminate fluid from circulation. And remember, the hydrothorax is a serous fluid, a blood-like fluid. We see this very commonly with cirrhosis or ascites, and it can be with or without cardiopulmonary or pleural disease. It does not have to have any cardiopulmonary involvement or a pleural disorder either. Patients that are in end-stage liver disease, are more at risk for these hepatic hydrothorax or hydrothoraces. And with the pleural effusion, we want to evacuate any of the fluid when we have a pleural effusion that is greater than 500 mLs. So we want to definitely intervene with patients for a thoracentesis when their pleural effusion volume or that hydrothorax is greater than 500 mLs. We see that the fluid will pass through the peritoneal space into the pleural space. So we're moving from the abdominal space into the pleural space. And where would these pleural effusions occur for our patients? Is it going to be on the left side of the lungs, or is it going to be the right side of the lungs? Yeah, you would see these on the right side. Remember, the liver is under the right diaphragm, right hemidiaphragm. So most likely these patients are going to present with a right-sided pleural effusion. When we look at common causes of these conditions or these diseases, when when we look at common causes of these diseases or these disorders, when we look at common causes of these disorders, this is mostly coming from abdominal ascites, patients with chronic kidney disease, or it could be a complication from a surgical procedure, and it can be corrected with the termination of that procedure. So when it comes to patients that are receiving peritoneal dialysis, this is fluid that's accumulating in the abdomen and having a way to withdraw or evacuate or eliminate all of that fluid in the abdomen is what peritoneal dialysis is. We'll break it down a little bit more, but essentially it's removing of fluid from the abdomen. It could be parapneumonic. This is an underlying pulmonary infection. So if we have that pneumonia that is building up lots and lots of consolidation and lots of secretions, it can lead to a loculated pleural effusion. So when we look at the underlying pulmonary infection, these are going to be mostly staphylococcal or pneumococcal pneumonias. So if you see staphylococcus or staphylococcal pneumonia or pneumococcal pneumonia, be wary of or be leery of patients accumulating a pleural effusion. The loculated pleural effusion just tells you that it's bound or it's adhered or attached to the pleural surface. So when we look at the things that we want to identify or take care of or intervene with when it comes to these pleural effusions, we want to definitely escalate the intervention with a 50% if your pleural effusion is identified as a 50% or greater of a hemothorax, we definitely need to increase the level of care that this patient's getting. If we recognize that there is we want to if we can, whenever we're doing the thoracentesis, we want to make sure that we can culture the fluid and do a gram stain on that fluid so that we can identify what bacteria, if there is a bacteria, or what germ is associated with that fluid. Especially when we have that purulent fluid, we want to make sure that we do a gram stain, we do a culture and sensitivity so that we can get the patient on the appropriate antibiotics, so that they can be treated for the condition that they have. When we see that the pH is less than 7.2, remember we talked about running the pleural fluid, that sample, through a ABG machine. We can look at the pH, and if we see that the pH is less than 7.2, we have some moves to make. We are thinking that it is more of a condition. It's more of a disorder that's going to need more care. I don't know. When we look at the pH, when we look at this pleural fluid, one of the things that we can do, and we talked about it before, but we can run the pH of the pleural fluid. And if we see that the pH is less than 7.2, we have some work to do. We can also measure the glucose of the pleural fluid. And if it's less than 60, we've got some work to do. So one of the things that we can do as far as treatments is going to be looking at the thoracentesis. We've talked about this. I will upload the actual PowerPoint to our course so that you can tap into this video on the thoracentesis. We want to make sure that our patients are getting on antibiotics. Remember, we did that gram stain. We're doing the culture and sensitivity so that we can identify what germ is populating, or what germ is so we can identify what germ is growing in that patient and get them on the appropriate antibiotics. These patients may end up with a chest tube or a pigtail catheter, whether it's the large bore or the small bore. We will look at taking care of draining that fluid over a period of time, especially if the pleural effusion is continuing to produce fluids. We could have intrapleural fibrinolytics, so these will help create we could also have some intrapleural fibrinolytics. This is just like what we talked about with the talc powder, creating instilling a medication that creates inflammation. This is instilling medications that will create an inflammatory response and help seal up any leak that may be occurring between the hydrostatic and oncotic pressure, sealing off and We could look at intrapleural fibrinolytics. What these are, they're very similar to what we talked about with the talc powder with the pneumothorax. We instill these fibrinolytics, and what they do is they create this inflammatory response, which will help eliminate the accumulation of fluid in the pleural space. And if it comes down to it, we could end up with a thoracotomy, which is removing. And then we have a procedure. And then we have a couple of procedures called a thoracotomy and a decortic. Then we have a couple of procedures that's called a thoracotomy and a decortication. Decortication. With a thoracotomy, what we're doing is we're creating an incision between the ribs to access the pleural space. Very similar to what we have to do with the chest tube, but with the decortication, what we're doing is we are removing some of the pleural lining so that with the decortication, it's an incision very similar to, well, it's a thoracotomy incision and removing of what's called the pleural peel, which is where the pleural fluid is escaping into the pleural space. So if you can remove that and seal that up surgically, that is what we're talking about with the decortication. So a few different treatments and things that we can implement, maybe recommend when it comes to the pleural effusion. Some other common causes of these particular Some other common causes of a pleural effusion would be a nephrotic, which is we have the kidneys that are not able we have the kidneys that are unable to keep up with the amount of fluid that's in the body, and you end up with a result of a decrease in the plasma's oncotic pressure. So if your oncotic pressure drops, then the hydrostatic pressure will become greater than the oncotic pressure. And when your hydrostatic is high, the fluid will evacuate, the fluid will escape. So you change the net pressure of the pleural space with dropping the oncotic pressure, and you get fluid that rushes into the pleural space. Typically, we see this in both lungs when it's nephrotic in nature. We talked about it before, the pulmonary embolism or an infarction. The infarction is actually necrotic tissue as a result of the stopping of blood flow. So the difference between the pulmonary embolism and pulmonary infarction. The embolism is the thrombus itself that is broken loose. The infarction is the tissue that becomes necrotic as a result of no blood flow. When we look at this, about 30 to 50% of our patients with a PE end up developing a pleural effusion. The right-sided heart failure, we talked about that with the cor pulmonale, and the infarction is that blood flow or that tissue that no longer works the way it's supposed to because it's dead and dying tissue. When we look at exudative, remember that exudative is going to be higher in proteins. It's going to be higher in lipids. It's going to be higher in lactate as well. So exudative. This is going to be our empyema, or our thick fluid. Typically, we see the empyema is going to have purulent fluid or pus in the pleural space, secondary to some sort of inflammation. So empyema could be from an inflammatory response from a pneumonia. It could be from a number of different things, but it is a result of the inflammatory cascade leading to pus or purulent fluid in the pleural space. It could be a malignant tumor. This can be from breast cancer. It can be from lung cancer. It can be from lymphatic cancer. It looks at the normal reabsorption in the pleural space. Nope. When we look at malignant pleural effusions, what we're talking about is an impact to the normal reabsorption of the fluid that's in the pleural space, and that is what is impacted. So these tumors can obstruct the lymph nodes. Remember, our lymph nodes is our garbage truck. They're the ones that are removing or eliminating all the extra waste out of our pleural space and moves it back into systemic circulation. But we can end up with tumors. That are in the lungs, the breast, or the lymph system that end up obstructing that outflow tract of the lymphatic system, leading to a backup. When you have that backup of fluid, it's going to spill back into the pleural space. Or you have another source that is chronic exposure to asbestos. When we look at pneumonia, we have bacterial, viral, and fungal pneumonias. 40% occur with bacterial pneumonia. So 40% of the time you will end up with a pleural effusion with a bacterial pneumonia. Only 10% of those, though, need any sort of therapeutic intervention. And what we'd use for those are additional antibiotics. So when we have that patient that develops a pleural effusion that is needing an intervention, it only happens 10% of the time, and we can get that gram stain, that culture and sensitivity on that fluid so that we can get them on the best antibiotics possible. When we look at viral pneumonias, we're looking at myoplasma pneumoniae or rickets. Rickets or myoplasma pneumoniae are the two causes of viral pneumonias that will lead to a pleural effusion. When we look at the fungal pneumonias, remember these are the ones that we see with the histoplasmosis, coccidiomycosis, and the blastomycosis are different types of fungal pneumonias that can lead to a pleural effusion. Other origins of a pleural effusion, you can have something that you can have a pleural effusion from tuberculosis. You can have one from some sort of GI impact and vascular. So you get a number of impacts or a number of causes of these exudative pleural effusions, TB, GI impact, and even vascular, that are leading to different pleural effusions. So it's crazy how much we have to be aware of, because so many different conditions can impact the pleural cavity or the thoracic cavity for that nature.